Good morning, good afternoon, good evening. Welcome, everyone. Ladies, gentlemen, guys, gals, and non binary pals. I'm Monique Springer, Project Officer with UWIHARP, and I'm joined today with Kelia Anderson, our Project Assistant. A very special welcome to our students, staff members, colleagues with the National HIV/AIDS Commission, off campus partners, repeat visitors, and to our new guests. UWIHARP is the HIV Sexual Health Unit at UWI, and we seek to positively influence the sexual and reproductive health and wellness of the university population and the wider Caribbean society. Our primary focus is the development of sexual health literacy among the community through programs such as our digital dialogues. These are sexual health conversations and will be held during the semester. They include the S Files discussion series on a wide range of topics, which we concluded last week, and the Shock series, which will focus on sexual health issues among our vulnerable Caribbean populations during COVID-19. You can look out for the flyers on our social media platforms, which include Facebook, Instagram, the UWI app, and through UWI student emails. We do have a few participating guidelines. All mics are muted and videos are turned off. Q&A will take place after the presentation and the mics will be unmuted. We ask you to post your questions or comments during the presentation in the chat pod located at the bottom of the screen. We aim to address as many as possible at the end of the presentation. Alternatively, you can message either me or Kelia directly if you prefer. For those questions we couldn't get to, please email them to uwiharp@cavehill.uwi.edu before the end of the day, and we will address them shortly afterwards. The sessions will be recorded, and the recordings will be posted afterwards on our social media platforms, including our YouTube channel, UWIHARP Cave Hill. These will be done without sensitive personal discussions to protect participants' confidentiality. Please note that we cannot guarantee confidentiality in this public forum among participants, so be cautious about what personal information you disclose about yourself and others. It is safer to talk in general terms. Please complete the evaluation form that will be sent to you after the session. You can suggest topics that you're interested in for us to facilitate. We do have a few rules which have been adapted from HIV 2020 online. UWIHARP's digital dialogues provide a safe space to address a range of sexual health topics using a sex-positive approach. We encourage participants to share their knowledge, experiences, and opinions in a respectful manner. You may disagree with views highlighted today. However, please be respectful of other outlooks, regardless of your religious or moral beliefs. Let us be mindful in the way we discuss sensitive topics. UWIHARP operates on a zero tolerance policy for any kind of abusive, discriminatory, belligerent, or disparaging comments or actions that may cause distress to presenters and/or participants. Persons who engage in any undesirable behaviors will be immediately removed from the webinar unannounced. UWIHARP's guiding principle is to first do no harm. And today we have our second shock conversation. These are online conversations about COVID-19. And today's topic is prioritizing sexual health and rights during the COVID-19 humanitarian crisis, inserting the Caribbean into the global response, perspectives from the United Nations Development Fund, UNFPA. And we have a very special guest today, Dr. Denise Chavans-Vogel. She is currently the HIV/AIDS officer in the UNFPA sub-regional office in the Caribbean, which is based in Jamaica. She's a public health, HIV, and gender specialist with significant experience in gender mainstreaming in public health and development projects, policy planning, implementation, and management, including in Jamaica and the Eastern Caribbean. She worked with national, international, and regional public health and donor organizations, specifically the Pan American Health Organization, or PAHO, Caribbean HIV/AIDS Alliance, the United Nations Population Fund, and the World Health Organization. She possesses a PhD in epidemiology from Switzerland, where she based her empirical research on gender and health behaviors in relation to HIV and sexually transmitted infections in an inner city community in Jamaica. I now invite Denise to talk to us today and share her. Thank you, Denise.
Okay, so let me start again. I was thanking you, Monique, and expressing my appreciation for you having me, for you and your team, the UWIHARP team, inviting me to this very important conversation. I very much liked it, speaking from the trenches, because this is what COVID-19 has been about. So thank you very much for having me. I'm looking forward to the exchange and um, the ideas that we will come up with. I would also like to express sincere appreciation to my UNFPA colleague, the Barbados and STIs UNFPA liaison officer, Denise Blackstock. So my presentation today, characterizing sexual and reproductive health and rights during COVID-19, I'm first going to give just a brief introduction of UNFPA and what we do. I will set the context of sexual and reproductive health, HIV, and GBV, because it's impossible to understand our response without understanding the context. Context matters. I will also speak about what UNFPA's response has been during COVID-19, what are the successes, the challenges, the lessons learned, and our recommendations. And then I'm hopeful that we can conclude with a nice, robust question and answer session. So with your permission, because I keep getting unstable internet messages, I'm going to stop my video to conserve on bandwidth. But I must say though, one great thing that COVID-19 has brought us, I think in many ways it has opened up these conversation spaces, because before we would have needed an airline ticket, per diem, hotel accommodation to go to a seminar. And now look at it, we're all together. Jamaica, Barbados, across the Caribbean is wonderful. I'm seizing positive vibes, lessons, and the benefits, the advantages, because we're going to have to seize it, because COVID-19 is going to be with us for a little while. So with your permission, I am going to stop my video so I conserve bandwidth. Okay, next slide, please. Right. So UNFPA, we have been operational in the Caribbean since 1969. We serve 22 countries in the English and Dutch speaking Caribbean. And our main office, the sub-regional office, is based in Barbados. We have five field offices with liaison officers. So Barbados and OCS is Denise Blackstock. We also have offices in Belize, Guyana, Suriname, Trinidad, and Tobago. Next slide, please. So UNFPA, or the United Nations Population Fund, is the specialized agency of the United Nations for sexual and reproductive health and rights. And we seek to deliver a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. We have 3 transformative results, which include 0 maternal deaths, 0 unmet need for family planning, 0 gender-based violence, and harmful practices. So our work, and we work with government, civil society, regional partners, and other UN agencies to achieve the Sustainable Development Goals by 2030, with a focus on health, which is goal 3, gender equality, which is goal 5, goal 10 on reduced inequalities. But there are also other goals that our work contributes towards. For example, partnerships is going to be very important. Later on, I'm going to mention the situation of the Caribbean in terms of resource mobilization, and we're going to need partnerships for that. But at the center of our work is the creation of an enabling environment for integrated sexual and reproductive health and rights, strengthening national capacities to advocate for and deliver policies and programs for access to HIV and sexual and reproductive health information and services, as well as reinforcing legislative and protective mechanisms for the implementation of laws, policies, and programs to prevent gender-based violence and sexual violence against women and girls within an integrated sexual and reproductive health HIV GBV framework. Next slide, please. So we also have a role in humanitarian, responding to humanitarian crises, and COVID-19 is the most unprecedented humanitarian crisis that UNFPA has had to contend with. Our specific role during humanitarian crises is to prevent excess maternal and newborn morbidity and mortality, prevent the transmission of and reduce morbidity and mortality due to HIV and other sexually transmitted infections, prevent unintended pregnancies, prevent sexual violence and respond to the needs of survivors, to distribute sanitary and hygiene supplies to affected women and girls, and to plan for comprehensive sexual and reproductive health services that are integrated into the primary healthcare system as quickly as possible. Next slide, please. So there you have just an idea, right? You have an idea there of what some of our work has been in response to hurricanes. Folks, climate change is a real something. And the fact is that they are increasing in ferocity. The Caribbean comprised mainly of small island developing states, subject to external shock and subject to climatic change. And the extreme weather conditions that we're experiencing now. Jamaica has been undergoing severe flooding as a result of ETA, and we've run out of alphabets, and there are others. So this is an example of some of the work that we've done in the last few years, distributing dignity kits in the Bahamas as well as Trinidad and Tobago. Not only to the citizens, nationals, I should say, but also those persons who are migrants and those persons who have irregular status in the country. Because from a human rights perspective, our mantra is we leave no one behind. Next slide, please. So there you have an example of some of our results. In the interest of time, we'll move to the next slide because I want to start giving you some context, right? So here we are. What is the profile of sexual and reproductive health in the Caribbean? It's typified across the region by early unwanted pregnancies, HIV infections, sexually transmitted infections, and related illness and death. And all of those account for a significant part of the burden of disease among adolescents as well as adults. We also have health systems that are plagued with systemic weaknesses. Sometimes the national resources don't necessarily match up with the health priorities. We face a brain drain of qualified health providers who go north. We have an aging population in some countries with zero growth or decreasing populations with fertility rates below replacement levels, such as in Antigua, Barbuda and Barbados, Bahamas, Dominica. We have unmet family planning needs is also important. Although there has been a decrease, we need to be able to continue that. Limited access to sexual and reproductive health commodities such as oral contraceptives or Depo-Provera injection, condoms, and so on, including male and female condom, as well as lubricants. We have limited access to that, and that's primarily for adolescents. The pernicious issue of access to comprehensive sexuality education, I'll mention that a little later, and also persons living in poverty. And those could be rural poor or urban inner city poor. Poverty is an issue. Next slide, please. Maternal mortality. Maternal mortality ratios have stagnated and remain virtually unchanged. And for that reason, many countries, including Jamaica, did not meet the Millennium Development Goals on gender equality because of an unchanged and stagnating maternal mortality ratio. Some of the key underlying factors for maternal mortality appear to be lifestyle related, including hypertension and non-communicable diseases such as obesity, diabetes, and also HIV. And the notion for many women, especially many women who have had multiple pregnancies, that they've been there, done that, antenatal care is not seen as a priority. So that is on one end for older maternal deaths, but among younger maternal deaths, it could be as a result of unsafe abortion, which is why that segues into my next point on adolescent pregnancy, which continues to be a tremendous health concern as well as a population and development issue in our sub-region. Approximately 20% of live births each year occurs among adolescent mothers who lack access to quality adolescent sexual and reproductive health and rights services, especially those adolescents younger than the age of consent. The age of consent is 18 in several territories, but for example, in Jamaica, the age of consent is 16, and adolescents younger than 16 years of age are unable to access sexual and reproductive health services, in spite of the fact that we have early age of sexual initiation and other problematic issues such as incest and other gender-based violence problems such as rape. Because of the poverty, things like transactional sex occurs just for basic economic survival. And when you frame that, that's why I wanted to give you the context, when you frame that against the situation of lack of access to comprehensive sexuality education, you begin to understand why adolescent pregnancy is an issue for us. Next slide, please. HIV. That first bullet there, I'm sure you've heard it already. Unfortunately, the highest incidence of reported AIDS in the Americas and the second most affected region in the world after sub-Saharan Africa. The prevalence is significantly higher among transgender persons at 51%, and among gay, other men who have sex with men. Of course, for those persons where the intersectionalities coincide, for example, with sex work or with poverty, it's even more exacerbated. We need to discuss, when we're talking about integrated sexual reproductive health, HIV and GBV, also speak about those intersectionalities. Sexual orientation and gender identity is one such. Poverty is another. Disability is another. Can you imagine the situation of someone, a transgender woman who sells sex and who is hearing impaired? Very, very problematic. What kind of access does such a woman have even long before the advent of COVID-19? But continuing with the situation with HIV, countries continue to grapple with the incomplete agenda of ending the HIV transmission and achieving the 1990 targets. There are large gaps across the HIV testing and treatment cascade, even though we have to take note of the successes that Guyana has had in achieving the first 90, Cuba, Haiti, and Suriname who have achieved the second 90, and Barbados and Suriname that have achieved the third 90. Next slide, please. Gender-based violence is something that we must address because, as you will hear a little bit later, this is something that is directly correlated, and we have seen an increase with the lockdowns, the curfews, imposed as a result of COVID-19. Just let me get a few definitions out of the way, because very often people use the term interchangeably with other terms. Gender-based violence, or GBV for short, is an umbrella term for any harmful act that is perpetrated against a person's will and that is based on socially ascribed, that is gender differences between males and females. So gender-based violence can occur among men, less so, but I want to get away from the idea that GBV is only a women's issue. It also occurs among men. Yeah, but although we know that most cases are among women. The term GBV is commonly used to underscore how the systemic inequality between males and females and the roles ascribed to men and women, which exist in every society, acts as a unifying and foundational characteristics of most forms of violence perpetrated against women and girls. The term GBV, that's the point I was making a while ago, is also increasingly used by some actors to highlight the gender dimensions of certain forms of violence against men and boys, particularly some forms of sexual violence committed with the explicit purpose of reinforcing gender stereotypes. So for example, among transgender persons or gay and other men who have sex with men, violence against such men is deemed to be gender-based violence. Next slide, please. Right, now we get to the advent of COVID-19. Just first identified in December 2019, by January to March 2020, it had spread worldwide in the Caribbean. Here in the Caribbean, we have in 33 countries, over 4,564 deaths. Some countries are already in community transmission. Jamaica is in community transmission, and I know also Trinidad and Tobago is in community transmission. The potential exists that COVID-19, and we're seeing it, will exacerbate those persistent and serious sexual and reproductive health, HIV and GBV challenges that already existed in the region. And that's why I wanted to lay the foundation and the context. COVID-19 will exacerbate existing inequalities and also the systemic weaknesses in the health, social, and other development sectors. COVID-19 has already caused widespread devastation to the economies in the region that are largely based on tourism, and the majority of us are. And as the pandemic continues to roll through the region against the background of those persistent struggles that we have with contending urgencies for financing, including limitations in the health infrastructure, high incidence of non-communicable diseases. The primary causes of mortality now are non-communicable diseases, increasing crime and violence, weak performance of males in education. There are gender differences that unequally that affect men and women, we have to say. Climate change that I referenced earlier, a destructive hurricane season. And at the same time, we now have other infectious diseases, for example, dengue. I don't know about the rest of the Caribbean, but here in Jamaica, we are seeing an uptick in dengue, and we're going into the flu season. I must reference those communities that are disproportionately affected because of the financial hardship and social disparities that they always experienced, and which are now going to be worsened by the COVID-19 pandemic. And those vulnerable groups that I'm talking about are women and girls, female-headed households, persons with disabilities, LGBT persons, and other gender non-conforming, gender non-binary groups, and persons living with HIV. Next slide, please. Right. Yes. Right. Correct. That's it. Yes. So you've heard me referencing, and here now I'm getting into what the response from UNFPA has been within the context of the impact of COVID-19 on sex and reproductive health, HIV, and gender-based violence. We've witnessed increased pressure on the health system, a reallocation of health resources and priorities to respond to this pandemic. And that means, for example, diverting healthcare workers from sexual and reproductive health to work on the COVID-19 frontline as those healthcare workers become ill. And this was brought home to me in no uncertain terms when I tried to reach members of staff at the Ministry of Health and Wellness here in Jamaica, and wasn't able to do so. And when I finally did, I learned that they had been ill and in quarantine. There was also no one to immediately replace them because these were senior level staff. But in the pandemic, everybody's now on the front line. And so that is a real issue that we're going to be faced with, the issue of health resources, which in turn results in restricted access to sexual and reproductive health and rights services, including maternal health, neonatal health, and safe birth care. Remember, I already flagged what some of our persistent sexual and reproductive health problems have been prior to COVID-19. So we have to be very careful to ensure that COVID-19 does not translate into increased maternal mortality ratios, which were already stagnating, and newborn morbidity and mortality. And you see that link and that nexus there, because often when the mother dies, the baby dies. So hence the need to approach it from that integrated perspective. Other impacts: limited access to contraception condoms, including male and female condoms, and lubricants, as well as other family planning services and information to prevent unplanned pregnancies and unsafe abortion, inadequate access to HIV and STI treatment, care, and support, in particular with the impact on persons living with HIV, key populations, persons living with HIV, sex workers, transgender, gay, other men who have sex with men. And I mentioned limited access to age-appropriate comprehensive sexuality education as a result of the closure of schools, the closure of vocational institutions, and the fact that many adolescents are at home, perhaps locked down with perpetrators. And so not only the increase in gender-based violence, but also the fact that they don't have access to that comprehensive sexuality education to empower them, to give them that locus of control, that self-esteem, to be even able to negotiate themselves out of dangerous situations. Next slide, please. Right. Reproductive health commodity security system. That is that system that provides reproductive health commodities that goes from the demand creation on the ground through to forecasting, planning, procurement, COVID-19 interrupted supply chains. The Caribbean doesn't manufacture oral contraceptives or IUDs or implants or Depo-Provera injections. We have to procure them. At the beginning of the COVID-19 pandemic, when supply chains were interrupted, this has had an impact on stockouts of reproductive health commodity security. Another issue that I should mention in terms of the impact of COVID-19 on sexual and reproductive health rights is the vulnerability of healthcare workers. Remember, I said that many persons are taken from sexual and reproductive health to work on the front lines. They're going to be exposed to COVID-19, and there's going to be a need for PPEs, personal protection equipment, to help limit the spread of the pandemic. In most of our territories, healthcare workers are primarily female. The face of a healthcare worker, especially among the nursing staff, is a woman. Those women have particular gender roles. Not only do they have that professional role of delivering healthcare to patients, but they also have a gender role in the communities and in their families. And that distribution of labor does not end with the pandemic. So those healthcare workers are also at risk of some of those same sex and reproductive health issues and gender-based violence that I spoke about earlier. We've been talking about. Next slide, please. Gender-based violence, being locked down with the perpetrator, no connection with support groups, breakdown of the rule of law, the status quo changes, law enforcement agents have more power. Service providers may also abuse their power. So prevention of sexual exploitation and abuse of authority is going to be an important approach, and prevention of sexual exploitation and abuse of authority is one of the trademarks of the work of UNFPA in that prevention. In terms of health facilities, which are usually the main point of entry of survivors to get help, they may be overwhelmed by COVID-19, and GBV may not be seen to be life-threatening. Also, we have noticed that because of the fear of transmission of COVID-19, many persons don't go to health facilities. The economic burdens, the psychological distress living in confinement, COVID-19 exhaustion can become a contributing factor also to an increase in different forms of gender-based violence. The limited availability or access to shelters and safe housing options for self-abusive women and other persons affected by gender-based violence makes it hard for them to leave. Shelters may not be functioning, or they may be repurposed to serve as quarantine and isolation facilities. And where women, majority of households are headed by women, over 60%, where they're not able to leave with their children, where the shelter does not provide for the women and the children together, that is going to be a challenge in terms of her being able to access and escape from a situation of violence. Next slide, please. So the key priority areas in UNFPA's response in addressing those sexual and reproductive health issues and the impact of COVID-19 have been to continue sexual and reproductive health services and interventions, including protecting the health workforce working and in doing so, we have been working in collaboration with government and civil society partners. We have to address gender-based violence and harmful practices. We have to ensure the supply of modern contraceptives and reproductive health commodities. And we also have to engage in community risk engagement and communications on sexual and reproductive health HIV and gender-based violence, and the intersection with COVID-19. The kinds of health services that we have to ensure stay in place are in relation to prenatal care, delivery care, including emergency obstetric and newborn care, postnatal care, including postpartum family planning. Next slide, please. So we have been able to have quite a bit of success in terms of training midwives in maternal health as we collaborated with the Caribbean Regional Midwives Association. That's why I said, folks, that the work of UNFPA is about partnerships. So goal 17 of the SDGs, because we can't do it alone. We also have been working in collaboration with international Planned Parenthood affiliates across the region, training them in family planning counseling by Reproductive, Planned Parenthood associations in 12 countries, and the sexual and reproductive health services that we've been focusing on, family planning methods, HIV and STI testing, treatment and care, GBV counseling and referrals, and psychosocial support services. Next slide, please. I spoke about the PPEs. So we have been able to distribute 2,500 PPEs in total to providers of sex and reproductive health services in Trinidad and Tobago, Belize and Barbados. And in Jamaica, we were able, under the multi-partner trust fund, to procure PPEs for sexual and reproductive health services. Those are currently being provided. We've also done sexual and reproductive health and GBV work with CSOs in St. Lucia, Dominica, and they are on track to receive a combined total of 51,000 PPEs in the coming weeks. Next slide, please. In relation to gender-based violence, which is so culturally embedded, you know, what is a slap? You burnt the dinner. Gender-based violence, folks, and I have to say that if I use Jamaica as an example, femicide, the intentional homicide of women, we have seen an uptick in femicide. Jamaica has the unfortunate statistic of being the second highest, having the second highest femicide rate after El Salvador, because gender-based violence is so culturally embedded. So in order to address GBV across the region, UNFPA has been engaging in mapping those GBV services, and we've been able to finalize that for 12 countries, where we've been able to identify the key providers and available services so that we are able to develop referral pathways for survivors and those persons at risk of GBV. Those referral pathways are going to be critical. And the referral pathways take a multi-sectoral approach where we look at health, the judiciary, police and security, and social service, psychosocial support. Those are all an intricate part of the multi-sectoral response to GBV. In the work that UNFPA has been doing, in addition to those referral pathways and the companion guide for non-GBV providers, and there's currently a training of trainers being conducted now, so I'm sure in due course you'll hear more about the companion guide and the referral pathways. We have trained hotline operators at GBV response organizations using mobile data plans, because of course everything has to be mobile, or using telemedicine and remote access services. We've been able to do that. We've been able to develop COVID-19 infection prevention and control guidelines for GBV shelters. These have been widely disseminated across the Caribbean. We have also hosted a webinar session on GBV during COVID-19, providing practical guidance and tools for countries to plan their responses in a coordinated manner, ensuring adherence to global best practices. Next slide, please. Risk communication and community engagement is important. You have to give people the messages in a rights-based way, and also taking account of the intersectionalities that I mentioned. Those intersectionalities, I remind you, women and girls, sexual orientation and gender identity, sex workers, persons with a disability, persons living with HIV, the rural and urban poor. Those are some of the intersectionalities that we talk about. And so when we speak about risk communication and community engagement, we have to do our outreach in such a way as to leave no one behind, and to offer messages that are sufficiently differentiated and nuanced to respond to the needs of persons across the continuum of intersectionalities. We've been able to reach over 200,000 persons across the Caribbean with sexual reproductive health, GBV, and COVID-19 communications products using social media. So leaflets, brochures, posters, radio messages, podcasts. We're able to include messages. Yeah, those are, again, are some more of the messages that we develop. Next slide, we can move on.
Kamal.
Youth, we have not forgotten our youth. And this is Kamal Clark, who has, because we had a youth engagement, we were able to attract youth to participate in the Caribbean Youth Against COVID-19 campaign, where we developed 27 videos. And there were youth groups who developed these in Suriname, Barbados, Belize, Trinidad and Tobago, and Jamaica. We were able to raise awareness on 6 thematic areas, translate videos in Dutch and other Surinamese local languages, and to reach over 12,000 persons on Facebook and other social media platforms, young people. Next slide, please. Earlier, I referenced reproductive health commodity security assessment and supply chains. It is important to have a robust reproductive health commodity security system in place in our country, because we have recognized that stockouts of commodities occur. When stockouts of commodities occur, you're going to have unplanned, unintended pregnancies. You're going to have an uptick as a result in unsafe abortions. You're going to have an increase in HIV and other sexually transmitted infections. So having a robust reproductive health security system that takes into account planning and forecasting, not only in times of normalcy, but also in times of humanitarian crises and unexpected emergencies such as COVID-19, is important for countries to have that capacity. UNFPA has therefore been conducting a reproductive health commodity security assessment across the region, which looks at the enabling environment for reproductive health commodity, the demand satisfaction for family planning, how to improve the procurement system and processes of reproductive health, as well as maternal and neonatal commodities, how to improve access and availability of reproductive health and maternal and neonatal commodities and family planning services, how to strengthen the capacity for supply chain management, and finally, how to improve planning, monitoring, and reporting, because without the data, we're unable to do evidence-based planning of policies and programs. Next slide, please.
Hey, Dr. Siobhan.
Yes, time?
10 more minutes.
Okay, great. I'm on my last couple of slides. I'll go quicker.
No
Next
problem.
slide, please. Thank you. Thanks for the time check. I get very excited about this. Assessing young people's needs. How will we know what the young people need? Remember when I set the context of what happens with comprehensive sexuality education, age of consent being 18 for many young people, 16 in the case of Jamaica. Young people have been unable to access sexual and reproductive health services, comprehensive, adolescent-friendly, gender-sensitive, quality adolescent sexual and reproductive health services, in spite of those pernicious challenges to their sexual and reproductive health, early age of sexual initiation, the incest, the sexual violence, the poverty that drives them into transactional and commercial sex. We have to listen to the young people to hear what their needs are. And so UNFPA has been doing an assessment, and it's currently underway in order to be able to identify the sexual and reproductive health, HIV, and GBV needs and risks of young people that have particularly emerged during the time of COVID-19, and to be able to estimate the severity of the conditions faced by young people, men, boys and girls in all their diversity and vulnerability. Next slide, please. So the objective will be to create a common understanding of the differences according to those intersectionalities. It will reflect the diversity of conditions faced by different groups of young people, because this is not a homogeneous group, and we are going to have to nuance and differentiate our responses according to the level of risk and vulnerability. And so in so doing, we'll be able to make the strategic recommendations and priorities to effectively address sexual and reproductive health, GBV, HIV needs and gaps that have emerged or been exacerbated during COVID-19. Next slide, please. These are the challenges. Limited availability and access to data that has always been problematic, but it's become much more so in the time of COVID-19, especially since there's some countries that are facing community transmission. So when resources get diverted, where systems were originally weak, and that's why I wanted to reference the health infrastructure. It's been further compounded and worsened, weakened, and exacerbated by COVID-19. So limited availability and access to data, legislative barriers to adolescent sexual and reproductive health, the continued opposition to comprehensive sexuality education. Many persons think it's about sexual grooming of adolescents. That's not the case. No evidence exists to show that comprehensive sexuality education is going to promote early before GB rates of patients, and I can reference as a result of that the Ministry of Health capacity, and finally supply chains have been interrupted. Next slide. So the way forward, well, we have to, until we have an effective vaccine that is available and accessible here in the Caribbean, and you would have heard the announcement a couple of days ago that there's great news on the horizon that a vaccine may become available. We have no idea what the feasibility of that is going to be in the near future in the Caribbean, given the fact that it's a fragile vaccine that requires refrigeration at sub-zero temperatures. You can imagine the cold chain. We're already back in the days of the expanded program and immunization, had a challenge in keeping vaccines for immunization, keeping the cold chain for it to get from central level down to the field. Can you imagine now with getting that vaccine out? So a vaccine is never ever a replacement for the public health measures that have to remain in place. So the mask wearing, the social distancing, the hand sanitization must remain in place. At the same time as we seek to scale up COVID-19 interventions and remote service delivery, strengthen national capacity for the data systems, and utilize disaggregated data, including from the census, continued strengthening of national capacity to better prepare and respond to emergencies and pandemics, continued advocacy for removal of legal barriers for adolescent sexual and reproductive health, use the analyses from the youth assessment to strengthen our programming for youth sexual and reproductive health, utilize the findings from the Reproductive Health Commodity Security Assessment to strengthen the capacity in each country and in the region as a whole, strengthen advocacy for the maintenance of HIV treatment, care, and multi-month ARVs, and continue to do the resource mobilization to fill the funding gaps. Next slides, and I'm almost finished. Just leaving you with some technical publications that are available to you on this slide and the next slide. As you continue to do your work, COVID-19 Agenda Lens, important reference. This is going to highlight the special needs of persons, especially women and girls, but other gender non-conforming groups. So transgender, LGBT groups, sex workers, special risks there. The healthcare workers, the majority of whom are women. Again, that is going to give you very important information there. And then my next slide and my final slide is to again acknowledge my colleague, Denise Blackstock, UNFPA Liaison Officer for Barbados and the OECS, and the young man that you saw, Kamal Clark from the Barbados Family Planning Association. And with that, I thank you for your time and attention. Over. Happy to take any questions and for us to discuss more.
Denise, thank you so much for such a fabulous presentation and for, really emphasizing, reminding, outlining, highlighting the importance of sexual reproductive health, especially in times of these such as COVID, which is classified as a humanitarian crisis. I just want to maybe point out one or two things. Maybe between them we can get maybe some questions, which hopefully Keely would be able to field to primarily you. But some of the things that I noted that particularly stood out during your presentation, I noted the systemic inequalities being exacerbated during COVID, and hopefully with the publications that you provided, that those of us who are doing work in this field then will be able to get a sense of exactly how this was played out. Especially you spoke and drew emphasis on gender-based violence and the exacerbation of sexual and gender norms, especially among women and girls, the gender non-conforming groups, and the LGBT groups, and especially the disabled. We haven't really been hearing conversations of their vulnerabilities during COVID and linking it with SRH. So I think that was really important. That really stood out for me as being an important factor really to think about, but also the healthcare workers and and we've seen that here in Barbados, being reallocated to other priority areas during COVID away from SRH. So a lot of these SRH services really were not being offered here either. But also what we haven't really heard much about in the Caribbean, the healthcare workers themselves being quarantined, being infected, and no one replacing them, and the double day burden of care that many of the healthcare workers who are women have to confront when they are frontline workers and then have to go home to do their double day at home. What came up, I think, for us in Barbados, particularly, the stigma that many of the healthcare workers themselves were facing, especially working in the COVID centers. And, majority of them were women. And to the extent that many of them could not even wear their uniforms on the street because they were being, accosted basically as being having COVID and being transmitted. And it reminded me of the days of HIV stigma, those attached to HIV, working in HIV field. Even myself, I was told by one of the healthcare workers on campus that one student wanted to came to me for services, but we don't offer clinical services. I had to refer them to the clinic, and I was told, well, it's best if I don't come with them to the clinic, because it's an automatic assumption if a student is seen with me that they're HIV positive. So there's some of us that are involved in this work ourselves that are positive, targeted and stigmatized. But certainly that came out for me in your presentation, and I think what really stuck me was or grabbed me was the rates of femicide in Jamaica. That that there's even a rate for this region that really stuck with me, and Jamaica being the highest, second highest rate in the LAC region, Latin American and Caribbean region. So that really concerned me. And just one other point, if there were no other, oh, I have lots of points, but before Kelia, any questions coming?
Not as yet.
Not yet. Okay. Definitely ASRH, adolescent sexual reproductive health services. Those of us involved in this work understand we're having this issue here too in the Caribbean, the disconnect between age of consent and age of access to services. Because our age of consent is 16, but adolescents can't access services, so they can get pregnant and give birth, but they still need some kind of guidance, parental consent. This is to access services. So that is going to be, that continues to be an issue. Some other things I wanted to maybe highlight, just following some of the global chatter on on sexual reproductive health during COVID, especially when it first came out during the early days in the summer. And one thing that really stood out for me, especially here in Barbados, that sexual reproductive health services were not prioritized in the COVID response, right? And you pretty much highlighted that as well when you spoke. But then certainly issues around supply chain disruptions because of shutdowns, lockdowns, halting of international domestic transportation. But you also went into reduce access to SRH services to women and girls, and the gender non-conforming groups as well, and having unmet needs. So a lot of things I think that those of us in the field, we're confronting, but I don't think the general public really has an understanding or awareness of what is happening within SRH, and how COVID has really impacted on this field. But from your position then at UNFPA, what would you say are your lessons learned from your position of where you sit at UNFPA during COVID?
I would say that among the lessons that we have learned at UNFPA is the importance of a gender transformative, integrated sex and reproductive health, HIV and GBV approach, with a focus on intersectionalities such as age, disability, sexual orientation, and gender identity. It's important for us to provide SRH, sexual reproductive health and rights information and services to protect against COVID-19, as well as to ensure that reproductive health services, including the prenatal care, the assisted delivery, emergency obstetric care, are available and maintained, because people don't stop getting pregnant and having babies. It is important to ensure continued access to family planning services to reduce unwanted pregnancies through a strengthened reproductive health commodity security system. And how do we get the commodities out to the communities where people need them? That's going to be important. Also, with an emphasis on dual method use. Dual method use is the use of a hormonal contraceptive as well as a male condom. Hormonal contraceptive for the prevention of an unintended, unplanned pregnancy, and the condom for the protection against HIV and other sexually transmitted infections. or reproductive health commodity security system also has to include emergency forecasting and planning, because Monique, we are all small island developing states. We're all subject to external shock, climate change, severe and worsening climatic and weather systems. Jamaica's preparing for another this weekend, just by way of example. So responding to the needs of vulnerable groups and persons living in poverty. They already did. They were already poor and vulnerable before, and they are even more exacerbated. We have to pay attention to their needs.
Yes.
Women and girls, female and male sex workers, and other vulnerable groups. We have to strengthen HIV combination prevention approach, including the promotion of treatment as prevention and retention in care in a gender transformative way. We have to focus on continuing to promote multi-month dispensing of ARVs, even though persons will typically, who are stable, may get a prescription for multi-month ARVs. When they go to the pharmacy, they don't get multi-month ARVs because there are challenges with supply chain.
Yes,
the supply chain. And if people are unable to be retained in care, we know
lost the care
are. Exactly. They will lost the care, lost the follow-up, no longer be in zero. Yeah. Strengthening the monitoring and data collection. We need the data. We need the data. And that's why I'm so excited to be having this discussion and conversation with UWIHARP. University is well placed to do this research. More research is needed, Monique.
Correct. I agree.
Yeah, including primary, secondary, and tertiary healthcare. Yes,
that's right.
And not just women, but women and girls, vulnerable groups. Those vulnerable groups that many persons don't discuss. But in order to leave no one behind, there are certain frank conversations about trans, LGBT, lesbian, what it is, lesbians, gay, bisexual, transgender persons. Right now, Jamaica is developing a transgender health strategy, taking the focus outside of HIV. Transgender persons are tired of being considered vectors of HIV disease.
Of course.
And want to have their comprehensive health needs across the life cycle addressed. So Jamaica is doing that now. UNFPA in collaboration with UNAIDS, we're working on that now. Maintaining the continuity of sexual and reproductive health services by protecting sexual and reproductive healthcare workers. Yes, you face stigma and discrimination among sexual and reproductive healthcare workers in Barbados. So did we here in Jamaica, where taxi drivers didn't want to pick up the nurses. They would see them in their uniform and not pick them up. Yeah, and you're right, because I've been in the HIV field for many years too. And I remember the early days, Monique. It's almost the same thing. And I think we have to use the lessons learned from the HIV response and apply it to COVID-19. And what that tells us is a human rights approach, involvement of the communities. So the civil society organizations that work with the communities, the various communities, a differentiated and nuanced approach. It's not one size fits all.
Correct.
We have to listen to the needs of the people as expressed by the people themselves and then craft the innovations. But I am hopeful that COVID-19 has forced us to be innovative in a lot of ways. Telehealth services, remote counseling services. Look at us speaking here. And we didn't take a plane. and, this is an opportunity. And so this exchange of information, the South cooperation, that is important. The sharing of lessons learned, good practices will help us to replicate and scale up across our region. Because I think all of us face similar challenges. All of us are classified as upper middle income, which means, guess what? Operationally, we're not attracting resources.
Exactly. That is another issue.
Yes. Yeah, in
And
spite of the fact that, yes, go ahead. I'm sorry.
no, go ahead. I want you to finish up your point.
Yes, so in spite of the fact that we have those inequalities in the distribution of wealth, so we have a lot of poverty. We're classified as upper middle income and middle income for the most part. But that macro aggregation, that economic statistic, the inequalities in the distribution of wealth that creates pockets of poverty, vulnerability that coincide not only with adverse sex and reproductive health and HIV, but also COVID-19.
Oh, definitely. Thank you so much for
Is
that
our
very
so
broad, comprehensive perspective, Denise.
how do we address that? Yeah.
Thank you so much. I something I also had a question about your about or what your plan of action recommendations would be, but it sounds like that you've already made those recommendations. So the question would be your call to action. What would be your call to action in a humanitarian crisis that we're having? Let's say we had to go back to the beginning and we now know what we know. But I think you pretty much outlined a lot of those steps and issues that you have just recommended. But then I wanted then to ask one question, and then I think Kelia has a question from the floor. But I wanted to ask if UNFPA has been working with community health workers throughout the region, because I know, for example, we had our very first shock. We had some of the two family planning associations talk with us. We had one from Barbados, one from Belize, and one from Belize particularly um, spoke about their engagement with civil society organizations during COVID in doing pap smears at home and for women and delivering family planning, commodities, and that type of thing. So I'm just wondering if, because I know UNFPA works at the state level and at the community levels as well. So I was just wondering if you had that opportunity or know of UNFPA's involvement with community health workers.
Monique, I'll come until Denise is able to reconnect.
Okay.
She,
Okay, I want to also acknowledge you, Denise, another Denise Blackstock from the Barbados UNFPA office, and your colleague Angela Savory, who is with us. Thank you very much. Denise, maybe you can jump in until the other Denise comes up back on.
Sure. Yes, Monique. I mean, we have been working with the Family Planning Association, which is our civil
Right.
society organizations, and they have maintain very close relationships with community health workers, and they've been instrumental in rolling out the support that we have been providing during COVID-19. For example, the deliveries, and I know BFPA has been doing a lot of that, and through Caribbean Family Planning
Planning
Association,
Association. Mm-hmm.
countries that have IPPF affiliates have been
Yeah.
that service, and we supported in the case of BFPA to have a medical doctor who was designated as the support for telemedicine and in going into the different communities and providing some of the health services, including the pap smear, and providing the commodities that they would need. And this was pretty, let's say, important for those persons who did not have access to transportation to be able to do pickup themselves, and so it allowed them to be able to still access family planning services delivered through the Barbados Family Planning Association. So yes, we have had experiences with that through our family planning affiliates who've been working very community level to ensure the continuity in sexual and reproductive health services. I know Tanya had a question in the chat about the telemedicine. And yes,
Telemedicine, yes.
Yes, and in fact, we supported BFPA and CFPA, the Caribbean Family Planning Association, to use the telemedicine app to where there would be online facilities to support screening and to make pre-appointments and to provide several services that would not have been available during the shutdown. I know that for CFPA, over 400 home deliveries were done and close to 100 in Barbados. And what the next step for us to get a better sense of how well it was received. We know that it happened, but just to get a better sense of the context, to get a better sense of how feasibly it was, or how it met the need that was identified. That is something that we plan to do, some documentation, because this is a novelty. It's a novelty for us. We've never done telemedicine, SRH telemedicine, before the COVID-19. And for us, it's very interesting to document exactly how effective it actually is as a form of remote service delivery. And just to make the link to like natural disasters, humanitarian context. And one of the things that we see, because even before in how we provided or services during humanitarian context, telemedicine was not a huge part of that. We would have surge go in to the countries to support the different organizations, and also the organizations themselves. When we were able to go in, telemedicine was not a huge part of how the support was provided. So we see the link, and we want to see how to scale that up going forward, and to have telemedicine and remote SRH service delivery be one of the, what you call it, strategies or the core components of how we deliver SRH services across different types of humanitarian contexts. So it's been very, very interesting. A lot of lessons learned for us that we want to document and strengthen going forward.
Great. Thank you so much, Denise. Welcome back, Denise. No, I understand. Welcome back. We had the other Denise from Barbados.
Yes. Thanks, Denise.
Jumped in, and she answered the question I had about working with community health workers. And a great question from Tanya about telemedicine during COVID, because I actually had that question to ask because it popped up in your presentation. But I think that is all for the questions that we have. I don't know if anybody has any other comments.
I'm afraid my internet is still unstable.
Right. So I'm going to close now. Plus we are 1:45. So, you know, just any last minute comments from you, Denise, from the other UNFPA'S, maybe from Kelia, any other comments before we close, and then I'll just do my thank yous.
I'll just say quickly before my internet goes down again. Yes. It was an honor and a privilege to be able to have this conversation with you. Thank you to Denise B for the collaboration, because she did quite a few of the slides. And the lessons learned that we're generating across the region will go towards those regional goods and services that we can scale up and replicate. There'll be a lot of lessons learned, a lot of tools and methodologies that will prepare us not only for COVID-19, but also from some other unforeseen, unplanned emergency, because that's what COVID-19 showed us, that we were not planning and anticipating eventualities such as the COVID-19 pandemic. Yet still, we know that the region is vulnerable. We're SIDS, small island developing state. We are vulnerable to external shocks. And so we have to do that forecasting and emergency planning as an imperative.
Yes, definitely. If there are no other comments, then I would just like to thank Denise Shivans and also Denise Blackstock and also Angela from UNFPA for a really, really good presentation, and reminds me why I love this discipline so much. From the engagement, just listening to you, Denise, makes my heart very warm for UNFPA and the UN again. Thank you so much for such a wonderful presentation. And also thank you to Kelia for helping out
welcome.
with the tech, and to our fabulous participants who joined us today. Thank you so much for coming. Just to let you know, next week we are going back to the trenches, stories from the trenches with Shock. We have the two representatives from the LGBT communities talking about their experiences. So please look out for our flyer and join us for that important conversation looking at the intersecting pandemics. That's actually what it's going to be called, that Denise spoke about, from looking at it from the LGBT and sexual minorities and gender minorities, their experiences within the pandemic. So hopefully you'll be able to join us for that important conversation. And thank you again to Denise for helping us with this wonderful talk today. And take care, everybody. Remember to fill out the evaluation form that Kelia is going to send to you. Take care, everyone, and thanks
Thank
again.
you. Thank you very much,
Okay,
Monique,
awesome.
Leah,
Thanks.
Denise B, and the rest of your team at UWIHARP. Looking forward
Awesome.
a lot of work to do together.
Awesome. Awesome. Always.
Yeah.
Thank you. Take care.
Okay, great.
Bye-bye.
Thank